a member of your regional network, please do drop us a line to find out who your chair is if you can't access it on the website, and we will put you in touch with them to join. It's definitely worth joining your regional network because although we hold open quarterly meetings now at NQI CAN, we cascade a lot of information out via those open meetings, but we love our regional networks to pick up that information and have those nitty-gritty discussions with other partner organisations across the systems of how you can then take that information forward within your own organisations and across your patient pathways. So it is really important that people are attending both their open meeting and their regional network meeting as well, and also to support our dedicated regional network chairs who are obviously trying to deliver all the drive and the enthusiasm for making sure that our national clinical audits and our local clinical audits do link up with the wider quality improvement plans that we've got going on within our own organisations and across the systems. Hence why we're here today, to have a look at some of more of our local clinical audits, and today's focus being on record keeping. We know that record keeping has come up a number of times on the forum, and the links here on the slide for anybody that's not yet a member of our network and sharing forum. And we have also got a request out for further topics, haven't we, Marina, so that we can put on some more local webinars. So this is to help you with your local topics in your organisations and across your systems, in addition to that massive plethora of national clinical audit work that we also have to engage in. I think that's probably all I want to say. Just a reminder that the NQI CAN inbox email is nqi.can1@nhs.net. So do drop us a line if you do want to be put in touch with the regional network chair. But please do visit our NQI CAN website. We are currently updating it, but it's looking looking better than it has done previously, but obviously we're trying to work with our regional network chairs to bring the information up to date. So like I said, you can go there to find out who your chair is, but drop us an email if you need to. Join the network and sharing forum. And also the other link that we've not popped on here is the NHS Futures website around the national clinical audit work as well. So I'll put that link in once we hand over to the speakers. But if you've got any questions, pop them in the chat. But otherwise, I think it's over to our 4 dedicated speakers who are going to share with us their examples of their record keeping audits.
Brilliant, thanks Vicky. And I realise, of course, I should have introduced myself. I'm Marina Otley, so I'm the General Secretary of NQI CAN as well. And as Vicky said, obviously this session's been put together based on the feedback that's come through and the inquiries that have come through on our forum about you know, sort of the need to understand record keeping audits. And as we've said, no one size fits all, but the idea was to bring together a small group of people to share their experiences so that you can take away examples and ideas for some good practice for going forward. So our first speaker, there we go, is Natalie Dean from City Healthcare Partnership, CIC. Over to you then, Natalie.
Oh, thank you, Marina. So as Marina's just said, I'm Natalie from City Healthcare Partnership in Hull. I'm a quality improvement practitioner, and I'm going to talk to you about what we call our Quality Matters 2 or QM2 record keeping audit. Before I get into that, I'll just tell you a little bit about CHCP. We are a little bit different. We're a community interest company that deliver community services, NHS services. So we've got things like GP practices, dentists, we've got sexual health contracts, we've got therapies, inpatient units, what else? We've got absolutely tons, and public health services. So that's just a few. There's absolutely tons. So that's just to give you a little bit of a background, which really reflects what Marina said earlier, is one size does not fit all. It definitely did not fit all for us. And when you think about the difference between sexual health, public health, and everything else. So we wanted to do something a little bit different to what we were doing previously. We started off doing some very generic record keeping, but it just did not fit all of our services, so it was quite difficult. So next slide, please. Thank you. So I've put this timeline in, and I'll go through sort of the audit questions, etc., as I go on. But I just wanted to really emphasise to people, this was not a quick turnaround. We started this was before our team even was a thing. in July 2017, our lead practitioner came up with a new concept about what we're going to do with record keeping. We wanted to do something different, as I'd said. So it was discussed and agreed, and the concept was born. And then our team was born, and there are only 3 of us. We are a very small team. And that went through. We did our proof of concept, our baseline audit. But it's just to show you some of the things that we've done along the way. So we've had a couple of external audits for sort of assurance around what we're doing. Is it all right? What sort of results are we getting? We've had a lot of changes, and obviously from a QI team, it's been continuous improvement all the way through. So it has evolved. We've always stuck with the same questions, but then we've got sub questions that have evolved and moved along with the audit. I'm sure you won't be surprised to see that we had a pause during COVID. And again, we had a little rethink and a little revamp of the audit when we restarted in October 21. We've very recently had another external audit, and we had a review within our team where we're just looking at next steps and what's it going to look like going forward. So from July 2017, we've got a lot of data and a lot of background now, but we're still going. So it's just really to emphasize, it really was not a quick fix. Yeah, it's a very different approach, but it's still continuing. Next slide, please. So to give you all a few more specifics, what we wanted to do, rather than asking sort of your generic record keeping audit questions, is we looked at the governance structures. So do we have good governance structures in place to support good record keeping across all of our operational services? And we had sort of 2 expectations really, is that services would have a service specific SOP, so a standard operating procedure, and that services would be looking at record keeping audits where they might want to ask some of those more generic questions, but maybe just for things that were more pertinent to that service, or things that they had a bit of a gripe about, or things that they might have thought, I'm not sure about that. So they could choose what questions they wanted to ask in relation to record keeping. I'll be real honest, when we first asked it, I think we might have been a little bit naive, and we just said, have you got a SOP? That's evolved over the process to, is it in date? Has it been ratified? Are people reading it? Do they read it at induction? Are people signing it? And similarly with the service specific record keeping audit, we look at, how often do you do that? Is anybody looking at the results? Does anybody follow the action plans? So again, those sort of sub questions have evolved over time, and where we've got to a point where we think actually everybody does do that now, we're really mean and we move the goalposts and we'll say, so what about this next thing? So it does evolve, but they're the main 2 areas that we've stuck with, and those questions are always the same, but we always want a little bit more, don't we? We always want a little bit more improvement, so we do change the sub questions within there. Next question. Next slide, please. So if you think back to my other slide with the timeline on, when we restarted for COVID, we actually added in what we call Part B. So Part B is utilised really, as I've put there, as a variable platform where if there are any pertinent organisational questions, we can add those in. So they are agreed, they're proposed and agreed via our integrated quality forum. And there can be something, it might come from datixes, it might come from themes and trends, it might come externally, somebody's asking us about something and we want to get an organisational view on it. And the ones that we've had so far have been capacity and consent. We've looked at organisational record keeping professional standards. We've done the data security toolkit, and when I said we did the October 23 review and evaluation of the QM2 so far, we actually asked our operational services some questions around there of what they've got from QM2. Do they find it useful? How do they use that as it improved record keeping? So we can put those types of questions in there as well, which is really useful to just have that bolt on. It might be a one-off. It might be something that we run for a couple of months to get a better baseline, or it might be something that we do with one off the baseline, we give the results back to whoever's asked for it. They may then have some interventions. They might want to re-audit, or they might go down a different path, but it's quite useful just to have that if there are anything where we want to get organisational involvement across the board. Next slide, please. So this is probably the one that everybody's thinking, well, you know, so what? Come on. When we stopped our previous record keeping audit, it was very much green across the board. Everybody was getting yes, 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 tick, 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 looked beautiful. But when we started doing this, actually what we found was it was quite low, which we weren't really surprised about, but at the same time, we were a little bit surprised when you think back to the sea of green we had previously. So as you can see, it took a while, and we supported people to develop SOPs. We've supported people to develop service-specific audit tools and audit questions. And, you know, how do we review that? How do they share that? And you can see just before COVID, we got up to, and that's an average score we've popped on there, an average score of 86%, and that was across around 50 services. So actually, we're pretty pleased with that. And then we had the COVID pause, and we did expect it to dip down, and it did. There was no surprises there. But then it's quickly come back up, and at the last time we audited, which was July 2023, we had an average score of 97%, which when you look at where we were, is fantastic. But, you know, it was a lot of supporting from ourselves, which is absolutely fine. That's what we're here for. But, you know, it didn't just sort of naturally wouldn't have happened without a push, with somebody being that person that would push within those teams as well. Next slide, please. So from the evaluation, we managed to create some top tips, and these have come from our services who are undertaking this audit. I'm not going to read them all out to you. Obviously, they're there for people to have a look at. But I would say the absolute most important ones on there are identify a lead within each service area, because you do need somebody from that service area really pushing it forward and keeping it topical. I'd also keep it simple. Like any clinical audit, we want to keep it simple. You want to make it easy so that people will get involved with it, and be really clear about what your record keeping, what does good look like with record keeping. So that's where your SOP comes in, and where your organisational policies come in. And there were some of the things that we've done a lot of work with services around. But overall, people absolutely, they really like it, and they're talking about records. They look at records in supervision, and they discuss these audit results and record keeping. Because we've got the governance structures in place, actually good record keeping has got better. And it's not a quick win. It really isn't, but it has really, really helped, and it is getting a lot better, which is just fantastic and really what we wanted from it. Next slide, please, which I think is just my thank you. And does anybody have any questions? I don't know if I'll let Marina tell us what we're doing with questions.
Yeah, we've got a couple of minutes for any questions for Natalie, and then obviously if anybody after we've had all of our 4 speakers as well at the end, there will also be some extra time for questions if anybody thinks of anything as well as we're going along. We've got 3 hands up so far, so Kate Martin first, please.
Hiya. Thank you, Marina. That was really interesting. I was just interested in the data you gave us there, which was sort of, let's say 86% is that of audits complete? Is that of good audit? What's that 86% represent to?
The 86% would be their overall, so it's the average overall score per service.
Of record keeping, of record keeping.
We would assign each of those questions a score. So to get to 100%, you would have to say yes, yes, yes to everything. So some of them are weighted. And again, that went through IQF as what they wanted the weighting to be with our business intelligence team. So yeah, obviously it's out of 100%. So the 86 would be the average score of all of our services. Obviously, I could break it down and tell you who got hundreds and who got less. But yeah, it's because we've got a weighted scoring system.
Okay, and just to tag on to that, I asked a question in the chat box, which was, would it be possible? Would it be possible to share a SOP with us, just so I got an idea of the kind of things that you're putting in there? Because presumably it's the questions that you're asking or the data that you're looking to gather. I'm keen. I'm the head of audit here, and I'm just keen to understand how I can add that governance to it, because at the moment it feels a bit like we're swimming around a bit ad hoc here and there.
No, we were exactly the same. What we gave the SOPs to the services and said, right, what does good record keeping look like for your service? So obviously that would be very different for if you're a GP practice to, if you're a dentist. But what does it look like? And they would have in there any professional requirements that they would have to do. And then if they've got any sort of electronic record system user guides, they'd put that in there. So this is what we need you to fill in. I need you to fill these bits in. This is why we do this. But I'm sure, that we could share something.
Okay.
I'd obviously just have to go back to the services and get their permission first.
Yeah, absolutely. Brilliant. Thank you so much.
Thank you.
Thanks. And then the next question is Victoria.
Hiya, thank you. I was just wanting to clarify, so it's the clinical teams themselves who are carrying out the audit in each area, is that right?
Yeah, so we send them the audit tool. We are there to support for anybody that hasn't done it before. And we're quite involved with the services as well, but they would then complete that and supply any evidence that we would ask them to supply. So sometimes we dip sample and say, well, you've said you've got this, can I have a look at it? But yeah, they would fill that in.
And was it quite easy to get their buy-in for that?
To be honest, because we've got such a good relationship with them, we do quite a lot of work closely with our services. It was, at first it was a little bit harder, but they just do it now. They're just really good. They know, in fact, when we've stopped for the pause, we've had people saying, you haven't sent me my email. I need to do my audit. So yeah, but it does take good relationships, which obviously you have to build up with services.
Yeah, and just one other really quick question. Did you say the audit's electronic notes, or are you guys paper notes still? How does that work?
We're mostly electronic now. We do still have some services that would do paper notes, but because we're looking at the governance side of it, they would pick that up within their service-specific audit. So if they were looking at a mix of paper and electronic, they can audit that, or whether they were fully paper. But the majority of ours are now electronic.
Real, thank you.
Thank you.
And then the next question is Rebecca Newton.
Thank you. This links to what Victoria just asked about the buy-in, and you said you've got good relationships, but in terms of the onboarding, because we often get a lot of resistance, we haven't got time. I suppose that was something you had as well, and how did you overcome that? Or was there something else that was kind of a barrier that you overcame? Like, any ideas? Appreciate you sharing.
Yeah, to be honest, a lot of the services were asking for some of this. They really wanted support with it. It linked in with sort of incident reporting and investigations and stuff. So they had that appetite to get it right. We did have some that were a little bit more hesitant and maybe didn't see the full scope of it initially. And it was just perseverance, to be honest. We'd keep sort of getting involved. Can we help you? And I often say we use a bit of a mech approach. So, every time we speak to somebody, we do a little bit, we chisel a little bit away. So I think it's sort of dogged perseverance, I think, is the only thing I can really suggest.
And I think that holistic overview as well about, well, this is how this links to your incidents and everything else, rather than it's tick boxing. Yeah.
And
so thank you.
Positivity, really. We're here to help. We're not here to give you another job, but let's keep it simple but meaningful.
Yeah. Okay, brilliant. Thank you. I really appreciate that.
No problem.
Carol is the next question.
Hi, yeah, I wanted to ask about your sample size and if you're using an online tool for the audits.
So for our audit with the governance structures, we sample all of our operational services. So it is a whole population sample. If we want to do, if we are asking them in Part B to look at any records, then it will, be quite a small sample of records per service, just because we've got 50 services, around 50 services to do. Sorry, what was the other part of your question?
If you're using an online tool for the input of data.
We don't at the moment. We designed an Excel. It was quite a complex Excel. I have gained rapidly some Excel skills, but yeah, so it is automated within the Excel. Everything sort of adds itself up and comes out with a nice report for us. But yeah, we are hoping to start with an online tool, just to make it a little bit easier, because that was complex, working out sort of all of the data. So, you know, if you have got anybody and you are looking to do this, I'm more than happy to chat to anybody about the Excel side of it. But yeah, you probably would appreciate somebody with a bit of Excel knowledge to be able to make that easier if you don't have an electronic fancy system that can do it for you.
Yeah, I mean, if you could share kind of like a sample worksheet, that would probably be quite useful for everyone, I think.
Yeah, no, that's fine.
Thank you.
I think we've probably got time for one more question for Natalie, and then we'll move on to our next presenter. Then if you do have any other questions, obviously we will hopefully have a little bit of time at the end of all our presenters. And I know Natalie said you're also welcome for people to email you as well.
Yeah, that's fine if anybody wants to email me.
So we've got one more question. I think that is Michaelina. Apologies if I've mispronounced.
Hi, no worries. So yeah, thank you for the presentation. So I'm just having a question as well about the sample. So thank you for answering. What was the frequency of how did you approach this? Because we do it quarterly, so I was just wondering whether you have more continuity, or sorry if I missed it in your presentations, but I was just wondering for.
No, sorry, it's a good question. I did mean to tell you that, and I don't think I did. Yeah, we did it quarterly. We've now, after the last external audit, they've said actually they would recommend we reduce the frequency to annually. Because it's very well embedded now. But yeah, quarterly, and that is, you know, from 2017 to now. So I would definitely think quarterly would be the minimum you would want to do this at the beginning.
So you rather were basing on sample, because we do currently add entries based on entries from, you know, from a case note. So it's just a bit different, but I think we just need to give it a go and start and see that will take us. Right. Okay. So, thank you very much for
lovely. Thank you.
Great, and we'll move on to our next speaker then. So then we've got Karen Thorogood from Kent Community Health next. Over to you, Karen.
Hello there, my name is Karen Thorogood and I work for Kent Community Health. So it's a community health trust. Could we go on to the next slide, please? Right, so we'll start. I'll just give you a bit of background to our trust. So again, as I said, we're a community trust. So like Natalie, we've got community hospitals, we've got therapy services, community nursing services, school nursing services, sexual health services, dental services. We are spread over Kent. We've got bases in inner and outer London and East Sussex. So we cover a huge area of ground. We've got, I think, on the last count, it was about 150 active bases. There's no central library or anything. So we moved to electronic record keeping about 10 years ago. We started with CIS, and then about 4 years ago, we moved to Rio. Specialist services use different systems. So there are various other systems in play, and our records link up to the NHS Spine, obviously, but also to the Kent and Medway Care Record. And that brings together all the health and social care records. So GP, acute, community, mental health, social care and ambulance care, I think, access it to give an overall picture of patients. So we're feeding into that. So next slide, please. So we have 5 separate divisions within the trust, and clinical divisions, and each of those divisions has a governance group that is responsible for their audit program. So within each division, you've got different things going on and agreed by them, and that includes the record keeping. So we were looking originally at trying to do a trust-wide one, but there was so much, and we want this and we want that and we want to look at this and we want to look at that, and we did it last year, so we only want to do a re-audit this year. So in the end, it's sort of like, okay, everyone do what they want to do. So that's what happened. So last year, well, in 2022-23, our public health and specialist health services, which are 15 different services, did one audit between them. They looked at 15 different standards, and then that everybody answered, and then added in service specific ones. There was an overarching report to highlight areas of good practice and share learning, and then everyone had an individual report as well. When we were looking at that, it was the equivalent. We added up the we worked out the median time it took to fill in one audit and multiplied it by the number of responses we had. So with that one, we knew we were looking at the equivalent of 31 days full-time data collection for somebody. And so we looked at that and said, okay, from what we're getting out of it, is there a better way that we could have spent that time? So when it came into the adults one, they looked at what they were doing, and at the time they were doing what was called the ad hoc monitoring of notes, which was a monthly huge record exercise in data collection that looked at anything that could be written down in a record and whether it was there and whether it was happening. But then it didn't really go everywhere. Every single service got an individual report every month, and it was up to them to do something with it. And I'm not awfully sure that anyone ever did. So we started reviewing what we were going to do this year with record keeping, and our medical director said, why are we doing it at all? We have electronic records. So many of the things that we used to ask is just a default setting. So we know who wrote it, we know what their designation is, we know when we wrote it, we know when they amended it. So why do we have to do one at all? And everyone had a feeling at the back of their head that you had to, but nobody could actually find where it said that. So I came out to NQ ICAN and posted a question. Do we actually have to do it? Does anyone know where this comes from? And some people came back and said, and actually nobody knew where it did come from, but that CQC had done a couple of inspections of places and marked people down because they hadn't done a record keeping audit. So it's okay, well, we'd better do a record keeping audit then. So we also have within audit at the moment within this trust a pledge that we will keep everything to a bare minimum, because the clinical teams are just so slammed that nobody really has time to be looking at it. So we looked at all of the colleges and associations and what have you, and we made a huge big grid that covered everybody's standards from everywhere. And then we looked at the ones that had the most commonality, and we drafted out something, and then we went through it and we took out everything that was a default setting on the systems we were using. It had to be a default setting on them all, because otherwise you'd get those variations. So all those questions came out. Then we looked at all the other audits we were doing, because in a way, every audit we do is a record keeping audit. You're looking at what was recorded when anyone did anything, and that's where your audit's from. So we took out anything to do with consent, anything to do with safeguarding, anything to do with any of the other trust-wide audits that we did. And then we were left with a core of 15 questions. And we asked each team to do 5 records. And they all were quite happy with that, especially given what had gone before. It was such a relief that they hadn't got this huge monthly thing. We'd said to them at the beginning, depending on what the outcome is, it will affect how frequently we do this. So if we quality rate or assurance rate all of our audits when we get them back. So it breaks down into no assurance, limited assurance, significant assurance, and full assurance. So if it was full assurance or significant assurance, we would do this annually. If we got limited assurance, it would be 3 monthly, and for no assurance, we'd do a monthly audit. Fortunately, we got significant assurance. And that's where we are at the moment. Everyone has fed in actions on the individual reports. We have an overall report with an overarching action plan. And that's where we are at the moment. We're working through our actions. I think there might be another slide, but I'm not sure. We're still on background. Oh, yes. So yeah, so there we are. Any questions?
Thanks, Karen. That's really good. Has anybody got any questions for Karen? Probably got a couple of minutes, and then we'll move on to our next speaker. Okay, got a question from Kate.
It's me again. Yeah, just interested to know what those 15 questions are. Really.
Let me have a look. So, well, actually, we started off with 13 questions, just trying to find out who people were who were asking. But then we asked about the record being synchronized to show and showing name, address, date of birth, and NHS number is up to date, ethnicity, communication needs, next of kin, patient preferences for data for sharing information.
Is it possible for you to sort of I'm trying to scribble them down madly. Is there a way you could just share them with us afterwards or something?
Yes, sure.
Would that be all right? Thank you.
Yeah.
As I say, if you want to send them through, Karen, and then you can either put them directly onto the forum post yourself, or send them to me and I'll add them to the forum post.
Okay.
Then for when we share the recording of the meeting and the slides. Any further questions for Karen before we move on to our next speaker? I'm not seeing any come through. Thank you again, Karen, and we'll move on then now to Diane Lynch from Dudley Group. Over to you.
Thank you. So I'm Diane Lynch. I'm the Head of Clinical Effectiveness at the Dudley Group and also the current chair for MEAN, which I've done for 8 years now. It's been very rewarding and I'm glad that Marina asked me to come and talk to you today. I don't think I'm going to give it as much justice as the rest of them because we haven't actually got a process for our record keeping at the moment, and that's kind of why I went to Marina in the first place to see if we could get that. So mine is more or less the background, the difference between electronic and paper documentation. So if we just go on to the next slide. So I've done some research on the difference between the paper and the electronic systems. And as you can see from the table, if you have a quick view of that, you can see that all the paper areas, it's all negative reasons that we should be doing them. So we've got expensive storage, lack of security. So basically anyone can view the records. We've got lost and missed files, and then we've got cancelled appointments because you haven't got the records, and they could be left out for others to see as well. So there's just no security and no having the notes secure. With the EPR, sorry. It's got an audit trail, it's got virtual space, it's got the cloud, it's all cloud based, so there's no expenses for that. And really the only cost for the EPR is the maintenance of the systems. So, you know, as you can see there, it's all the different areas and the negatives and positives. Okay, next page. So I did some word clouds around paper records and electronic. Oh, have I crashed?
No, we can still hear you, Di.
Am I still here?
Yeah, you're still on, don't worry.
Okay, so I did the word cloud around paper records, and again that came out as negative stuff as well. Unfortunately, the word cloud wasn't very good, and it separated all of my words from each other. So the things was missed appointments, ineligible. I can't say the word, sorry. Can't read it because the doctors don't know how to write, which then leads to the coding issues as well, and lost notes and the cost and all that kind of stuff. If you go to the next page. So again, it's broken it up again. So electronic, it was easily accessible, it's got audit trails, it's efficient and it's future proofed. So, you know, when we're looking at it like that, the electronic is the way to go. But unfortunately, there's no standards to measure against for electronic because essentially it should be a system that's auditable, and ours just isn't. It's just ridiculous. So we currently use Sumrise in our hospital. So these are some of the documents that we can get off the system, but we can't actually audit the system. So it just makes no sense to me. It stores all the info from all the way from ED to admissions. It's got all the documentation at a touch of a button for investigations from radiology. We've got nursing care documentation from AHPs and doctors' ward rounds. So all the information is sitting in that system. There is just no way to take it out really easily. It's just silly. For everything I've mentioned, if we undertook an audit on documentation, we're talking a minimum of 50 documents, and that's just not achievable. So, you know, what do we do? So if we go to the next page, so we used to audit the RCP, the Royal College of Physicians standards, and as Karen's already alluded to, those standards are no longer current because we're all electronic and it's all date stamped, so all that kind of stuff's just disappeared. So now we use these standards. Can you just click that link for me, Marina? Hopefully it'll work. No. Yeah. Okay, so I don't think the link's going to work, but basically there's 50 standards in this documentation, and it's broken down to admissions, discharging, the quality of the patient's records, and you know, it's where do you start when you're doing a documentation audit? What is the priority? Because before we had the Royal College and they'd set out, like, I don't know, I think it was about 25 standards, so it's clear on what we could do, what we needed to audit. But this documentation, it's got 50 standards, and you just, there's no way that people are going to sit and audit that on either a monthly or a quarterly basis. So it's, you know, it's where do we go from there? If you just scroll down, just to give you an idea of the kind of things that they're asking. So this, there you go, look, it's all broken down, and it equates to 50 standards for the whole lot, which is just impossible. So we just go to the next page. So instead of one audit tool, we had to develop one for each area. So at the minute we're sitting at, we've got one for admissions, one for discharge, and one for post-take ward rounds. But that still took a lot of resources from our team. It took a lot of investigations to see what is priority for each area, and then how do you break it down into the specialties as well. So, you know, it's just crazy. So if we go to the final page. So what do we do now? Well, this is the $1 million question. We just know the best way to, we just don't know the best way to do this. And it's really good that we've had some really good presentations here about what other trusts are doing. And I think it's just really important that we keep that conversation going about, you know, do we need to standardise for all trusts? Could essentially, most of us are electronic now. We've got a few areas that are still paper, but we're all aiming for the same outcome. So shouldn't we all be auditing the same kind of thing, the way we do with the NICE guidance? We've got set standards. Shouldn't we be doing that for record keeping as well, and just work through that way? So sorry, it was short and sweet. Any questions?
That's fab. Thanks, Di. Yeah, so we'll go to any questions or any thoughts or discussions that you want to have. So first up is Kate. Go for it.
Thank you. Me again. I know when I started looking into sort of audit on record keeping, I seem to be guided to the Professional Records Standard Body, or is that what it's called? I think I was just checking.
Yeah, that's the one.
So is that the same? Is that linked in with this document?
It is, yeah.
Yeah, okay, because that seems to give us the information that they want, but then not anything about auditing it. Just it's more about these are the standards that we should be seeing on every record. So that's fine.
Yeah.
Okay, thank you.
Okay.
Thanks. And then we've got a question from Moji.
Hello, everyone. Good afternoon. My name is Moji, Clinical Audit Lead at the Royal National Orthopaedic Hospital, Stanmore. I just had a question for any presenter really could answer this. Do you do these audits yourselves, or do you get all the clinicians involved sitting together doing the audits?
So from our point of view, we develop the tools, but we get the junior doctors and the registrars to complete the audits.
Okay, and do you get like the therapy, because the audit we do, record keeping at our trust, it has the pharmacists, the therapists, the doctors, the nurses, so get them all together to get the audit done. But sometimes it's really a big issue to get people to sit together. How do you overcome that? Do you then do it on their behalf, or because sometimes it just stretches for so long? How do you overcome that? Just looking for ideas here.
Just in our trust again, our specialties like our pharmacists and physios, they've got their own standards from their colleges, so they have to do their own mandated documentation audits, so they don't kind of feed into ours. Ours is more for medical doctors.
Okay. Thank
you're right, it should be multidisciplinary because they're all working together. So
we do an MDT one, multidisciplinary one, so we get everyone together.
Yeah.
But then getting everyone to sit at the same time to do it, it's hard work. Thank you.
Yeah.
Does any of our other presenters want to answer that as well? Karen, I think you had your hand up.
We do an electronic data collection. We use Snap software, and it's mailed out to the head of service, who then cascades it down to the nurses on the team, and they will collect the data. They do it for all of our audits. We don't get involved as a clinical audit department. We don't do any data collection at all.
Yeah, it's the same for us as well, Karen, in my with my day job hat on. Yeah, we do the same thing. We allocate it, we get the team, allocate it out to the team manager, and then get them to decide how it's allocated within the team in terms of who does that. And then we've got Tracy, do you want to come in first, and then Natalie afterwards?
Yeah, just to say the same as you, Marina, we actually, I mean, I think I'm up next anyway, but we had an online tool, and actually that was, the teams actually did that online tool themselves. I am the clinical audit department, so it would be quite difficult for me to do everybody, but yeah, we just did an online tool, and then we put up a paragraph on our trust intranet as to who could actually complete that audit and who and if they wanted to nominate someone to do it. And but I'll speak more about that I think I might be next anyway.
Yeah. Fab, thanks. And then Natalie, do you want to come in?
Yeah, so not for our governance side audit, but for our service specific audits, they agree within the service what they want to ask, and then they're very, very clear and have trained auditors. So the auditor might not be, a particular profession, but they have to understand what that answer would look like, so they can audit but answer for everybody, and then they share that back at their team meetings and talk through their audit results. So they might have a couple of different auditors, but they will cover everybody that it was in that service. So like for our pharmacy services, they have a separate one where they would look at the records from the services that they go into, but that's for them. But yeah, it's a real challenge, particularly when you've got lots of professionals working in one particular area.
Yeah, hopefully that's been helpful, Moji. Right, we'll move on to our next speaker then. So yeah, it is Tracy, you're up next if you want to go for it.
Thank you. Yeah, hi everybody, my name's Tracy Beach. I'm the Quality Development Lead for Sussex Community NHS Foundation Trust. We are a big community trust covering all of Sussex. We have over 200 plus teams, including 13 inpatient units with over 300 beds, so we're quite large, and a very small clinical audit department. You are looking at it for over 5,000 staff. So that kind of summarises who we are. So next slide, please. Right, so what approach did we take? Well, this is kind of slightly different story to the previous presentations because we haven't actually undertaken a health record keeping audit for over 4 years. That was due to the fact of obviously COVID, and the trust suspended clinical audit data collation, in addition to which my predecessor had left and the position was vacant for 9 months. I joined in July 2021, and about 2 months later was redeployed to the vaccination programme. So we were kind of left hanging, really. In the meantime, we were starting afresh. Back in 4 years ago, pre-pandemic, we were probably less than half electronic record keeping and quite mostly paper. Now we're all on System 1. So we had to really think about how we were going to run the audit and actually who was going to lead this audit. Previously, it had been overseen by the clinical audit lead, but we wanted to speak with information governance because actually we thought it should really fall within their remit as well. So the two teams, so both myself and the information governance team met to decide where to begin, basically. So next slide, please. So you can just bring all the questions up if you like, Marina. It might be quicker actually. So is health record keeping a clinical or IG responsibility? And this is one of the questions we talked about. Basically, it's an interesting conversation. It impacts both quality of patient care and our governance under data protection and record keeping responsibilities. But as you know, previous presenters have said, really, there is very little national guidance around any of this. And certainly nothing that we could lead this conversation with. And I keep saying, as it's just me in clinical audit and IG was a much bigger team, we've decided that IG would oversee it, they would lead it, with support from myself, where I'd support where I could for answering queries, supporting teams maybe, and helping with a bit of helping with analysis should I be needed. What should the scope of the audit be? That again, what had happened in previous years in our trust is actually a lot of scope creep had come in and more work streams had become attached to this audit. So it's become much bigger than a health record keeping audit. Suddenly we had clinical questions being asked, which actually we had to really think, is that health record keeping or does that then fall under another work stream? So we really try to strip out any of those real clinical questions that we thought were not actually related to health record keeping. As a kind of understanding, our previous audit had over 80 questions which was, yeah, we had to make a decision on that. Again, there's very little to define. It is tricky to define as there is little national guidance around the scope of the audit, and each professional body seems to have their own standards. Some are better than others. And as a community trust, we've tried to capture as much as we can in our own health record keeping policy. Again, I think has been mentioned, but in an ideal world, having a single standard for all our professions would be a real positive improvement that we could apply to our health record keeping standards. Interestingly enough, the next question, are we completely paperless? You would think so on an electronic records keeping system, but we are not. We have a huge amount of scanning that goes on to our electronic record keeping system. If you think we have, say, over 300 beds and every one of those patients has end of bed notes that need to be scanned up, there is still papers, record attachments in the community, in our community teams, they're scanning up possibly prescriptions for dressings, their letters, referrals. There's still a lot of paper actually, and what we decided, we are still very much two systems running. So the audit was going to have to cover both electronic and paper record keeping systems. And the other one was, when should we run the audit? Because we're starting afresh and because we hadn't run an audit in 4 years, we were very conscious that what we didn't want to do was run an audit at a really bad time for our teams. You know, our teams were under an awful lot of operational pressures. Although, you know, we were getting things in, the teams were saying, we're really keen to do this audit, we want to do the audit. Slapping it in the middle of the start of winter pressures was going to be great. Putting it in the middle of the summer when, you know, you've got half your team on annual leave, that's not going to be great. So we decided we would run it at the end of Q3. So to try and avoid going into the start of winter pressures and maybe capture when most people are coming back from annual leave. And we hoped that was going to be the best time to do it. And then should we ask all our teams of over 200 to complete this audit this time in one go? We really had no choice. We hadn't done an audit for 4 years. So how do we pick who we think should run it and who we think shouldn't run it? So we jumped in and we went, yep, we're going to ask everybody to do it. So, and that was our decision. That's the only way we were going to get the best assurance. So next slide, please. oh, what tool should we use? Yeah, so this is it. So again, we engaged our performance team to help with the toolkit, and they used Formic to create an online form for the teams to submit their audits. Oh, can we go back? Sorry. Thank you. So the toolkit consists of 6 pages with, we reduced the questions down to 44, but some of these were, they covered both electronic and paper, but some of them were conditional. So sometimes if you answered question 2 and you said no, you could just move to question 4. So not everyone was answering all 44 questions. The idea was the online toolkit would identify any errors on the page, and so that would require correction before the audit could be submitted. The idea behind that was then we had proper complete data submitted rather than spreadsheets coming in that might not be complete, or we may have to go back to the teams. We asked the teams to do 10 sets of randomly selected records, which, as we all know, randomly can fall into, well, let's select our best 10, but you know, what can you do when you've got over 200 teams? And what we did get was the online tool enabled staff to input their audits in stages by using a save and return option. And the idea behind this was actually to take the pressure off the teams, so they could maybe audit 2 records this week, and maybe in a couple of weeks they could audit another couple. So it wasn't right, someone's got to whack out a whole load of time and audit all these records. What we did do was communicate. The comms team were brilliant. We engaged them, and we had a page. We had it advertised on the front of our trust intranet that it was coming. I disseminated as many meetings as I could to say it's coming, be prepared. And we had a whole page designed with an explanation of why the audit was required, what teams actually had to do, a link to the audit tool so they could go and look at it ahead of time, and a paragraph on who could complete the audit with a team. So the comms team were absolutely brilliant, and we decided to give them 2 months, 8 weeks to complete their submissions. So next slide, please. What actually happened? So the online toolkit save option didn't work. Teams could not save their data and return to complete the audits. Lessons learned here straight away is do not assume. We did that awful thing, and it's screaming at everyone. I'm sorry, everyone's going, what, you didn't test your toolkit? No, we didn't. And we made that assumption when someone else did it, that it worked. No one tested it. Teams lost their data. They couldn't, when they put their records in and tried to save, they couldn't go back to it. My email was given as a point of contact. Another thing to do, check what communications go out. Again, it's so obvious, but when you're doing something like this, so as you can imagine, I didn't think the audit tool was going to go down. So when it did, I could not move for emails because everyone was trying to complete the audits, and they were, you know, IG contacted the performance team, who in turn engaged with Formic. This took time, and as a result, we had to disable the online toolkit until the save issue was resolved, which wasn't resolved for 6 weeks. And that was kind of out of our control because Formic is not actually part of our track. We're engaging outside. That meant we were in their line of priority. This meant we ran into winter pressures. So we actually, our audit then did exactly what we didn't want it to do, which was run into the start of winter pressures. So on top of everything else, teams were panicking. I was getting emails saying, when's it coming back up? When's it coming back up? The communication team, again, were brilliant. They put alerts up for us, but it didn't stop teams who knew we were coming to winter pressures still emailing me saying, when is this audit going to happen? So next slide, please. So where are we now? Well, the audit deadline was extended to the 8th of December. So as you can imagine, we are still analysing the data. We're still in the process of that. So we can't tell you what the assurance is at the moment. However, last count was 159 teams submitted data, which we are thinking is a really good return, a really good response. Services and teams who don't perform well will be offered support to implement improvements, and then we'll be required to re-audit within 12 months. It says in 12 months, but within 12 months, because this, will we re-audit all 200 plus teams yearly? No, we will probably focus on certain areas and make sure it's on a continuing rota rather than try and do all 200 again. In addition, we've just purchased InPhase, and I don't know how many trusts here are on InPhase. I know they're taking quite a few across. It replaces Datex as our reporting system, but we've also purchased the audit and clinical audit app. So clinical audit is going across to InPhase, hopefully February, March. So going forward, we're hoping to design this ourselves through InPhase, and it will give us more control over the form. It will give us more chance to test it. We hopefully will be able to also see how the audit is performing live, rather than have to wait to the deadline to see, what's going on. We'll be able to see if some teams are struggling, some teams aren't. So that's kind of where we are now. It's been a bit of a bumpy road, to be honest. But what I am happy in a few months to actually share how we've gone on with InPhase, if anyone would like, and also what our actual results are, because I feel I've got a little bit of a cheeky get out here, because I can say, oh yeah, 160 teams have been, submitted, but can't tell you what the results are. So I'm happy to share those when we've got it all together. So any questions?
Brilliant, thanks Tracy. Yeah, any questions for Tracy first, and then we'll open it up if there's any questions for any of our presenters that you've heard earlier as well. So we'll start with questions for Tracy if anybody's got any. You might get off with it. Oh, there we go. We've got one from Rebecca.
Sorry, Tracy.
That's all right.
I guess the question I've got is around the fact that this has become a more information governance audit. So, and I hate using the phrase tick box, but is it more about has it contained the information, sort of like, has it got their NHS number, nationality, and that kind of thing? Because one of the things we're looking at is more about the quality of the records. And so we're trying to move away from more of that, has it got this information? But then there is also arguably a need to make sure the record is containing that information. So I suppose, how has this been defined? What's the categories that's made this an IG audit and not a clinical audit in that way?
There is still ongoing discussion with that, if I'm honest. But I think as far as the electronic record keeping side of it was concerned, is that wasn't a tick box. That is automatically produced when the record is set up. So really we could strip back some of that. But the problem we had again was then we're scanning records up. And because the amount of scanning, we still had to have some of those tick box exercises. You're absolutely right around the quality of the record. Something I also do is I undertake the Sequin audits for our trust, and I have to, because our electronic record keeping system cannot run the assurance we need for those audits. I actually manually read 300 records every quarter to do the assurance. That's where we are coming in to improve the quality of our records as well, because it covers 3 big areas. And what we have actually seen is by focusing on that, what I have seen is a huge improvement in the quality of care being recorded, how it's being recorded, by actually focusing on that. Whether we can do that, we probably can't do that with this audit, because actually at the moment we hadn't run it for 4 years. So we needed to get assurance that at least we're reaching some kind of standard. I think when we start focusing on, we start drilling down and actually doing a rolling rota of areas and teams that we're focusing on, we can start actually incorporating more of that quality of the record rather than just the tick box element.
Great, thank you, Tracy. Got another question in from Carl.
Thank you, everyone, and thank you, Tracy and Marina. My question was more generic to everyone, Marina, and probably just to everyone as professionals, really. So my name's Carl Walker. I'm the Clinical Audit Manager at University Hospitals of Leicester and former MQICAN chair. And listening to all 4 presentations today, really good. You need to have approach to this, structured approach, otherwise it becomes an impossible job. And I think just thinking about it as I've listened to the speakers today, because we haven't got it sorted at Leicester at all, is you probably need to think about why we're doing it, and more outcome focused, like you say, the quality of the healthcare record, communication. Are we trying to reduce complaints because communication's poor, or we're duplicating tests because we've not documented them properly, or we're trying to reduce litigation and the like? And I think if we made it more focused around outputs, then you could actually quantify the need to do it more, because really snapshot 5 a month you know, whatever you want to do. It's all a bit arbitrary really, and it's not really statistically valid or sound, and you can just pick 5 good sets of notes and look like you're really good when actually there's a big problem. So I think we've just got to think about it as a profession, about why we're doing this. Are we trying to do it for assurance, and therefore to do robust samples if we really are important, if it really is important for us to do, or if we're trying to improve something, when we need to look at where's the risks, where are the errors happening in our documentation, and how can we minimize those going forward by putting in improvement plans and just testing interventions, etc. So I think that's just a thinking out loud comment really, more than to any individual.
Thanks, Carl. Yeah, some really good points there about in terms of when you're sorting out your record keeping audit, just, you know, making sure you're really clear, really focused on what's your main purpose, what are you trying to get out of this? Because, you know, yeah, as I think a couple of people have said, sometimes there is a bit of a danger there of things spreading, and because everybody wants everything included in your record keeping audit, because it touches on all the areas of your organisation, all those clinical teams. So people suddenly want to include everything, throw it all in there, and then it becomes unwieldy, as some of you have found as well with previous things. That's fab. So any final questions for our presenters then before we disappear off them for the afternoon, everybody? I'm not seeing anything come through. So yeah, just a big thank you really for our presenters who've shared your experiences today. It can, you know, it can be quite daunting kind of putting yourself out there and going, this is what we've done. But I really would encourage all of you to do so. We're going to have a thread on the NQI CAN forum where we'll share the recording from today and the slides, and of course feel free to also contribute as well in terms of, you know, putting on there copies of whatever data collection form you've got. I'll put ours on as well from CityCare, in terms of our data collection form. And please, you know, as I say, feel free to throw things on there, ask questions as well of each other, and let's kind of keep this discussion going. And if anybody feels brave enough to you know, or willing to put yourself forward for a future one of these kind of webinars, then please do get in touch, or ideas of what you'd like to see on these future webinars for looking at local record keeping audit, local clinical audit, tripping over myself now, then please also do get in touch with us. But yeah, so go and have a good rest of your afternoon, everybody, and thanks again very much.
Thank you, everyone. Goodbye.
Thank you. Bye.
Thank you. Bye-bye.
Thanks.
Bye.
Bye. Bye.